Good afternoon, everyone. First of all, I would like to thank the organizing committee for inviting me. I'm really sorry that I couldn't be there in person, but I hope to meet you all in the future. Yes,
Professor, your
over the
voice is
past
not audible.
years, PSMA-targeted theranostics have come a long way in the management of castration-resistant prostate cancer. Today, we will discuss how lutetium therapy fits into clinical practice, the evidence supporting its use, and how we can better predict and overcome treatment resistance. As you can see on this slide, PSMA is highly overexpressed in prostate cancer cells almost in 85 to 90% of cases. This makes PSMA an ideal theranostic target, meaning it can be used both for imaging and for therapy. On the therapeutic side, we use beta and alpha emitters like lutetium or actinium PSMA and newly diagnosed Auger and conversion electron emission terbium PSMA. Let's briefly review the key clinical trials that established PSMA-targeted radioligand therapy in metastatic castration-resistant prostate cancer. The first study that I would like to mention, the VISION trial, published in New England Journal of Nuclear Medicine in 2021. It showed that lutetium PSMA significantly improved overall and radiographic progression-free survival in PSMA-positive patients previously treated with RP and taxane chemotherapy. After this, lutetium PSMA was approved by the FDA. So in Turkey, we have been using this therapy since 2015. The second trial is therapy trial in Lancet Oncology 2022, compared lutetium PSMA with cabazitaxel and demonstrated higher PSA response rates and fewer grade 3 to 4 toxicities. And most recently, the PSMA-4 trial evaluated lutetium PSMA in patients progressing on RP but not yet exposed to chemotherapy. Its positive outcomes have led to expanded FDA approval in this year, allowing earlier line use before taxane therapy. These studies define the evidence-based indication for lutetium PSMA therapy. And you can see here contraindication of lutetium therapy. In all cases, patients' eligibility requires PSMA-positive disease confirmed by PET imaging, adequate bone marrow, renal, and hepatic function, and a good performance status, generally ECOG 0 to 2. The ANM and SNMMI procedure guidelines also recommend therapy to be performed in specialized nuclear medicine centers with standard dosing of 7.4 gigabecquerel every 6 weeks for up to 6 cycles, adjusted individually according to response and tolerance. I would like to present you two different patients in our clinic. The first patient was 82 years old, initially diagnosed in 2014 with Gleason score 7 prostate cancer. After radio and hormonal therapy, he developed disease progression with mediastinal lymph nodes and bone metastasis. He was chemotherapy-naive patient and he received 2 cycles of lutetium PSMA in combination with enzalutamide. His PSA dropped dramatically from 3 to 0.08 nanogram milliliter, and PSMA PET-CT confirmed almost complete response, as you can see here. The other patient was diagnosed with metastatic prostate cancer in 2019 with a Gleason score of 8. He received hormonal therapy, taxane chemotherapy, enzalutamide, and radiotherapy to the vertebra before our treatment. Later, he was referred to our clinic for lutetium PSMA therapy. At baseline, the lesion showed very little or no uptake of FDG PET, but there was intense uptake on gallium PSMA imaging. So we expected a good response. However, after 2 cycles of lutetium PSMA, there was a clear PSA rise and significant progression on PSMA scans. Even after one more cycle of lutetium and switching to actinium PSMA treatment, as you can see here, the disease kept progressing. So this case really raises an important question. Why did treatment fail in a patient who, based on imaging, seemed like an ideal candidate? Despite the impressive outcomes with PSMA therapy, about 1/3 of patients eventually develop their treatment resistance. We need additional biomarkers to identify which patients are most likely to benefit from lutetium therapy. I think one major factor is tumor heterogeneity. Lots of studies comparing gallium PSMA and FDG PET-CT have shown that some patients harbor PSMA negative but FDG positive lesions, suggesting aggressive, dedifferentiated tumor clones that are less responsive to radioligand therapy. In these patients, overall survival is significantly shorter, around 9 months compared with more than 20 months in PSMA-dominant cases. And this study focused on intrapatient intermetastatic heterogeneity. It's very recent trial study. A total of 98 patients were included, all of whom underwent both FDG and gallium PSMA imaging. Heterogeneity was also observed among lesions within the same patient. In 37 patients who had FDG positive but gallium PSMA negative lesions, additional gallium dotatate imaging was performed in this patient. Overall, intrapatient intermetastatic heterogeneity was identified in 82% of cases. They found a total of 12 different lesion imaging phenotype combinations were detected. As you can see here, patients with intermetastatic heterogeneity had significantly shorter median overall survival, 9 months versus not reached. So patients who had at least one FDG positive but PSMA negative lesions show a shorter median overall survival compared to those without such lesions, 5 months versus not reached. And finally, in patients who underwent gallium dotatate, the presence of at least one dotatate positive lesion was associated with shorter median overall survival, 3 months versus 6 months. Yes, after this point, secondly, tumor burden is so important. So when we look at the P subgroup analysis that is published in this year, the authors investigated whether PSMA tumor volume could predict PSA progression-free survival and overall survival. So basically, they showed that patients with higher tumor burden had worse survival. Using a cutoff of 234 milliliter, they demonstrated that PSMA tumor volume was a key prognostic factor, especially for those receiving enzalutamide alone. And a patient with larger tumor burdens may also benefit from lutetium plus enzalutamide combination, although this combination wasn't found to be statistically significant. Yes, another topic is genomic biomarkers. And in this study, they asked an important question: which genetic alteration might predict the response to lutetium PSMA therapy? They analyzed 126 patients who had received at least one cycle of lutetium PSMA and underwent next generation sequencing. Among them, 58 patients had mutation in DNA damage repair genes, and 59 had tumor suppressor gene mutations such as TP53, RB1, and PTEN. Patients with at least one tumor suppressor gene mutation showed shorter PSA progression-free survival and overall survival. On the other hand, the patient had DNA damage repair genes like ATM mutations, tended to have better overall survival, indicating a favorable treatment response to lutetium therapy. The last one is artificial intelligence. A few AI-based studies have been published indicating potential for better patient selection, but more data are still needed. Here I will present our department's clinical trial, which was published in 2022. In this study, 100 patients with metastatic castration-resistant prostate cancer received at least one cycle of lutetium therapy. Overall, 60% of patients experienced some PSA decline. After fourth cycle, among 45 patients who reached this point, 48% achieved a biochemical partial response, 26% had stable disease, and 26% showed biochemical progression. Patients with any PSA response after the first cycle had significantly longer overall survival than the non-responders. It means 17 versus 9 months. And also all patients well tolerated the treatments. I would like to show you one patient in this study. This is a 72 years old patient with a Gleason score of 9 and PSA of 3.1. He previously received radiotherapy, hormonal therapy, and 6 cycles of chemotherapy. After enzalutamide, he was referred to our clinic for lutetium PSMA therapy. As part of our routine, we perform FDG imaging for all patients planned for lutetium PSMA treatment. On FDG imaging, most lesions showed FDG uptake. We expected a more aggressive course due to the FDG uptake. However, after 2 cycles of lutetium PSMA, an interim assessment showed a very good PSA response and complete imaging response. To date, the patient overall survival is 96 months. We know that 1/3 of patients will develop resistance to this therapy. Unfortunately, we don't yet fully understand how to overcome resistance. I think the first question should be when to start lutetium PSMA treatment. The PSMA-4 study was able to answer the question of when to start lutetium PSMA treatment. I think the trial is so important. It showed that earlier use of lutetium therapy can improve outcomes in metastatic castration-resistant prostate cancer patients. In this study, taxane-naive patients who had progressed on RP were randomized to either intravenous lutetium PSMA or a change of RP. PSMA-4 trial showed that lutetium PSMA therapy led a clinical meaningful prolongation of radiographic progression-free survival compared with RP change in taxane-naive patients, 11 versus 5 months. Lutetium PSMA had a favorable safety profile with a lower incidence of grade 3, 4, or serious adverse events despite a longer median duration of exposure to study RP treatment. These results suggest that initiating treatment prior to chemotherapy may improve responses. Nevertheless, larger studies are required to confirm these findings. The second topic for preventing treatment resistance is dosimetry, I think. Dosimetry is so important. It is maybe most important parameter of this therapy success. There is some question like, was a lethal form thus administered? Are the dose and number of cycles appropriate? Are the dosing intervals appropriate? Actually, we don't have definitive answer to these questions yet, but studies are already underway. This is a phase 2 trial, and here you can see the study protocol. Patients were divided into two groups. The first group received the standard treatment, up to 6 cycles of lutetium PSMA every 6 weeks. The second group could receive up to 12 cycles with treatment breaks depending on the interim response. I believe that the results of this study will guide the design of future treatment strategies. And the third one, when resistance to lutetium PSMA treatment develops, switching to other radionuclides in another option, like actinium or terbium. The next talk will focus on actinium PSMA, so I will skip that part here. The preliminary results of the terbium trial were published last month in Journal of Nuclear Medicine, coming from a Turkish multicenter study. This was a prospective multicenter study. It included 7 patients who had progressed despite prior androgen receptor pathway inhibitors, taxane-based chemotherapy, and at least 2 cycles of lutetium PSMA. All patients had PSMA positive disease with no FDG discordant disease. Each patient received 2 cycles of terbium PSMA, 7.4 gigabecquerel per cycle, given every 6 weeks. Terbium PSMA demonstrated promising molecular and biochemical activity with a favorable safety profile in patients who had progressed after lutetium PSMA therapy. These preliminary findings support further investigation of terbium-based radiopharmaceuticals as next-generation therapeutic option for metastatic castration prostate cancer. In this slide, you can see here 4 of 7 patients showed a good response in PSA or PSMA volume, whereas 2 patients had progression in these parameters. Yes, the last question is when to consider combination therapies. Many combination trials are currently ongoing, and their results will guide our future treatment strategies. You can see here the trials. And thank you for inviting me and for your attention.